This was the largest paper in North America and certainly in the United States looking at radiofrequency ablation. We had 620 nodules. So there were 3 different institutions, 5 different RFA providers. The outcomes were consistent. At 1 year, the nodules shrank nearly 80% with one single RFA treatment, which is obviously phenomenal outcomes. In terms of what we consider a successful treatment, which is more than a 50% volume reduction, more than 75% of nodules achieved that within one single treatment. We also want to know about, okay, are there patient factors that are going to allow us to tell a patient, you're more likely to do well, you're less likely to do well with this treatment? What we found reassuringly is that for almost every patient and treatment variable doesn't affect the outcome. Patient sex, patient race, patient age. The technology seems to work for pretty much every group of patients.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Dipan Desai, an otolaryngologist at ENT Associates in Clearwater, Florida. He completed his residency training at Parkland Memorial Hospital and the University of Texas Southwestern Medical Center, and later pursued fellowship training in head and neck endocrine surgery at Johns Hopkins Hospital, gaining expertise in radiofrequency ablation and scarless thyroid and parathyroid surgery. Today, in addition to treating the full spectrum of ENT disorders, he is now one of the first physicians in Florida to offer these innovative procedures. His patient care philosophy is deeply rooted in compassion, respect, and open communication. He believes that personalized and collaborative medicine is the key to creating lasting improvements in his patients' health and well-being. He aims to work together with patients to find the treatment that is best suited to their individual needs. Dr. Desai, welcome to the podcast.
Thanks, Jen. Thanks for having me. Obviously, a phenomenal outreach platform that you have, and I'm happy to be a part of it.
Well, thank you so much. It's been really fun doing this for the past 5 years. This podcast has grown from something I just used to shoot with my smartphone to now I'm getting to interview amazing experts all over the world. So I'm really excited to talk to you today about your experience with training in RFA. You are the first doctor I have met who was actually trained in RFA during your fellowship. So I can't wait to get into that. You authored a paper about RFA. So we're going to talk about some really cool things today. But before we get into all of that, kind of just give us a little bit of your background about yourself, your training, and why you decided to even go into this field of medicine.
Yeah. Thanks, Jen. So I grew up in Texas and, obviously like a lot of us fell in love with endocrine and thyroid surgery along the way, but I took a little bit of a path that's less traveled. So I went to undergrad in medical school at the University of Miami as part of the BSMD program there. After that, went back to Texas, at the University of Texas Southwestern in Dallas and for my otolaryngology or ENT residency, and fell in love with so many other aspects of ENT, but really honed in on a passion for thyroid and parathyroid surgical care. And this was way before I even knew about radiofrequency ablation as a junior trainee. Just really loved the surgeries and that patient population. And so within ENT, interestingly, this is still somewhat of a niche. Our general surgery colleagues have had endocrine surgery fellowships for a long time. And even though we spend so much time in the head and neck doing big cancer resections and surgeries, endocrine surgery from a head and neck background is still a little bit of a niche. So ended up pursuing that, had good mentors who were supportive, and was lucky enough to match with the team at Johns Hopkins, Dr. Russell and company, for my 1-year fellowship there. And that was where I got exposed to thermal ablation and some of the things we're going to talk about today.
I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast. So you're actually from the South. You went up north for your training, and then you came back down to the South because now you're in Florida.
Yeah, as we finished up, with our time at Hopkins, my wife's a physician. She was working at Hopkins at the time too. We seriously thought about staying in that area with that program, but my wife's family is in the Tampa Bay area, and my parents moved to the Orlando area over time, and so the pull of family was really strong, and we eventually made the decision, albeit a difficult one, to join a practice here, and it's been amazing. It's a really large group called ENT Associates, 16 ENT doctors in private practice, allows all of us to kind of pursue subspecialty interests. Many of us are fellowship trained. And so I've been able to build a lot of the same things that I was doing at Hopkins in the community setting, which is great because we serve 3 counties,
Wow.
Pasco, Hillsborough, and Pinellas, 11 offices. And that's a catchment area of 3 million patients. And when we talk specifically about RFA, it's the South tends to be underserved compared to some of our big urban centers. And so in Tampa Bay, there was only one provider who was doing this. And I'm the first surgeon who's doing radiofrequency ablation for a population of 3.25 million people. So, it's been an awesome opportunity to grow a practice.
Wow. Incredible. Well, let's talk more about your fellowship training with Dr. Russell at Johns Hopkins. And what was it like for you coming into that experience and learning about, you talked about in your information you sent me that you were trained in radiofrequency, scarless thyroid, and parathyroid surgery.
Yeah.
All of this during your fellowship. And as I said, that's not something I've encountered to date in the last 5 years. For just a little context for the viewers, most physicians come into learning these really advanced, as you said, niche techniques after they've been in practice for a time, and they want to go up on their skills and expand them. And tell us about that. Kind of give us a little bit of a background on that situation.
Yeah, and I think this is kind of the typical, life cycle of any sort of medical innovation. The first people who pioneer this kind of pick it up and learn lessons from scratch, right? And often by tinkering and figuring out along the way in medical research what the most efficient ways to do that are. And we certainly are still doing that with radiofrequency ablation and thermal ablation in general. But I think we're at a point where there's certainly enough volume available to train the next generation of thyroid surgeons and proceduralists. So as you mentioned, I think the thing that makes that all possible is the incredible volume they have at Hopkins. So during my fellowship, we had 500 surgical cases. 100 of those were transoral scarless thyroid surgeries. That obviously makes for a really busy day to day. And then we had tons of radiofrequency ablation. So nearly 100 cases over the year. And because as a fellow, you operate actually as a junior faculty member, you have your own clinic, and I was able to do radiofrequency ablations of my own, as well as being part of the team that Dr. Russell performed with. And so over the course of the year, was able to do that in a way where, I can skip a few steps is the nice part, right? You're not starting essentially from scratch. The program's been in place with Dr. Tufano and Dr. Russell for over 5 years now. And so it was an awesome opportunity and allowed me to hit the ground running after training.
I would love to hear more about just the day-to-day. Like, how often were you doing these procedures? You said you did 100 over the course of a year. So what was that like in your day-to-day experience?
Yeah, and so the way Dr. Russell had this set up in his practice is kind of what I've emulated too. We obviously had a really busy traditional surgical practice, and so 4 days a week we're in the operating room. There was usually 1 day a week in clinic, and essentially once a week to once every other week, we would have a radiofrequency ablation day, and that would be anywhere from 2 cases to 5 cases. And that was really, we consecrated them all into 1 day in clinic. and kind of make it a back-to-back endeavor, a marathon day. And so my first day of fellowship was actually radiofrequency
Oh, wow.
ablation day. And so it was a really cool opportunity because I'd read about it as I matched into fellowship and learned about it. And part of the reason I chose this fellowship with Dr. Russell was because of radiofrequency ablation. And it was cool to see that on day one. And so we saw awesome outcomes for patients. And over the course of the year, also started to see the results of a clinical trial we were doing there where we were looking at early stage cancers. So what we call micropapillary thyroid carcinomas. In other countries, they've shown exceptionally good results treating that with radiofrequency ablation. Studies in China have shown comparable outcomes 4 years after surgery to the same as a thyroid lobectomy, which is awesome because the treatment time in those studies with radiofrequency ablation is under 5 minutes,
Oh,
which
my
is
goodness.
unbelievable. Yeah, and 90% of these nodules can disappear on ultrasound within a few years. Now, in the United States, that's still yet to be proven, right? We don't know for sure that those outcomes are going to translate. And with the C word, with cancer, we're
Right.
always hesitant to trial new things when things are quite effective. So we were over the course of the year, in addition to doing benign thyroid nodules, we began to do indeterminate or suspicious thyroid nodules if they were carefully selected, smaller than 2 centimeters in an appropriate location. And the results were really promising.
Wow. Can we talk more about that? That is a common topic of interest in our community right now. It's been probably for the past 2 years, it's been really growing in popularity. Patients coming to the community and looking for thermal ablation for their papillary thyroid cancers. And we've had to really educate the community on, as you were saying, when that's appropriate, when it's the right size, when it's in the right location. And of course, it's got to be papillary, right? We're not going to be treating any medullary or anaplastic.
Correct.
So let's talk more on that point. And are you treating thyroid cancers or indeterminate nodules in your own practice?
Very selectively, I'm willing to. I think we obviously work with amazing endocrinologists and radiologists who also do radiofrequency ablation. But I think one of the nice parts of coming from a surgical background is you can tell the patient, hey, this is what I think is best for you. And
Right.
I do have those patients who've seen me for that. And some of those patients I've told, hey, because of how this looks on the ultrasound or where it's located, I actually think surgery is better for you. And that's a hard conversation because people
Right.
come in with a lot of hope of avoiding surgery. And I offer them second opinions from people like Dr. Russell and Dr. Tufano because they may disagree. But I think we want to be judicious. We know that these have excellent outcomes with surgery too. And so if we find the right one that's in the ideal location and we can avoid surgery, that's a home run. But coming from a surgical background, the saying, if you're a hammer, everything's a nail comes to mind. We want to try to avoid doing that. We want to find what's right for the patient in every context. So I
Exactly.
do offer it, but for very select patients.
And I'm sure you're going to want to see those patients in person to perform your own ultrasounds.
Correct. Yeah. In general, for all of my radiofrequency ablations, the first consultation is about looking at the nodule myself. Sometimes I disagree slightly with the radiologist about the
Right.
measurements of the nodules or certain characteristics. And it's the same thing that we mentioned, a little bit of you can form a gestalt about what the nodule looks like. They may label it as a Tyrad's 4 nodule that's thought to be moderately suspicious. And I may look at it and say, no, that's not microcalcifications. That's actually common tail artifacts, and that's a definitely benign nodule, and feel totally comfortable treating that with radiofrequency ablation or vice versa. And so an ultrasound is part of my examination and at the initial consultation for everybody.
That's so important. I would love to touch on that again. What you were mentioning about the artifacts on the ultrasound. So patients often come to our community and they say, if I have these calcifications, does that automatically mean that this is cancer? And so kind of talk through what you were just saying a little bit more in detail about these artifacts, because those artifacts that they're seeing on the ultrasound sometimes can be calcifications, or sometimes they are actually talk about these artifacts.
Yeah, quite tricky, right?
Yeah.
Because We know that small bright spots can be microcalcifications, which don't inherently mean the nodule is cancerous,
Right.
but increases the risk of that.
Mm-hmm.
Ultimately, we defer to a biopsy, but we correlate what the biopsy says to the way the nodule looks. Because unfortunately, with one single biopsy, you do have about a 3 to 4% chance of a false negative, where the nodule is cancer, but the biopsy says it's benign.
Mm-hmm.
And so if the nodule looks really suspicious, especially in those cases, we will get that second biopsy, which is standard of care for most RFA doctors.
Mm-hmm.
But occasionally a microcalcification can be confused with something called a comet tail artifact, which is also a small bright white spot in a nodule,
Mm-hmm.
but is actually a sign that the nodule is very likely to be benign. And so
Wow.
even between radiologists or between surgeons, two people can look at an image and disagree. It theoretically should be 100% each time, but there is some subjectivity to it
Right.
when there shouldn't be. And so that's why I do my own ultrasound for every patient.
So important. Thank you for clarifying that, because that's a common source of anxiety for patients if they
Absolutely.
have those calcifications noted on their ultrasound report. So that's a very common question we get. So now let's kind of transition into your actual practice, and now you're doing these currently at your practice in Florida. Which when did you move to Florida and start join this practice?
Yeah. Yeah, I started my clinical practice here in Clearwater, Florida in October 1st of
Okay.
2023. And so just under a year into
Mhm.
practice now. And like I mentioned, my goal when I came down here was this is the community my wife grew up in. And, we're both from Central Florida now and wanted to bring everything we did at Hopkins here. So
Mhm.
tons of traditional thyroid and parathyroid surgery. And then also bringing in scarless and radiofrequency ablation. So we really built this program here with the support of my practice and with the support of the hospital system and the local medical community. So
Mhm.
seeing radiofrequency ablation candidates more and more frequently in clinic.
Mhm.
We see them in our Clearwater and countryside locations and do an ultrasound the day of and talk to them about the pros and cons of that.
Mhm. That's awesome. I know you said you had over 100 cases in your fellowship training. How about since you've been in Florida? What's the interest been in that area?
Yeah, it's been good. One of the biggest bottlenecks was getting the equipment, right? Getting the capital
Right.
expenditure. And so we recently acquired the RFA machine in the past few months, working with
Mhm.
some of our partners at RGS
Mhm.
and the ultrasound as well. And so we recently started doing our first few RFA cases. We have done a handful of cases already, and we have another handful in the queue scheduled over the next month or so.
Mhm.
And which is nice because obviously the adage in medicine is see one, do one, teach one. I was able to
Right.
see close to 100, do about 5 during my time at Hopkins, and then do an additional 5 here in private practice now so far. So
Mhm.
yeah, it's growing every day.
That's exciting. And I just thought of, I have a patient in particular in mind who's in Florida, and she
Mhm.
was treated somewhere far from home, and she was looking for someone to follow up with who was
Yeah.
local. Would that be something that you would do for patients who've maybe already been treated?
Yeah, I think that's reasonable. I think
Mhm.
initially, obviously, for your first visit or two, you should certainly see the person who took care of
Right.
you because there's some
Right.
intricacies of how much they treated, how aggressively, if there's any parts. But over time, obviously, we follow these patients long term, and so
Mhm.
6 months out, yeah, it's really cumbersome to want to go all the way to a different city or a different state to follow with
Mhm.
a surgeon especially if you've had a great outcome, and
Mhm.
it's more of just keeping an eye on things. And so
Mhm.
yeah, certainly happy to see those patients. That happens all the time back and forth within our community.
Thanks so much for watching this episode. I hope you're enjoying it. This podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in two different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast. Yeah, that spirit of collaboration is so important. That was my experience. I traveled. My doctor's in Texas now, but at the time when I was treated, he was in Virginia. I'm in North Alabama, so it was a good bit of a distance for me to travel
Of
for
course.
follow up. But it was worthwhile because I wanted him to have his eyes on that ultrasound, him to be performing the ultrasound. I
Absolutely.
had several doctors have said this to me in podcasts where they say ultrasound aren't pictures, it's a movie.
Yeah.
And so you've got to be able to see it in real time to really evaluate it properly. And so, I had several ultrasounds done locally by just the imaging center, and it was just really frustrating because we couldn't, nobody could agree on what they were looking at. The radiologist didn't understand it. And so, yeah, so I agree. It is really helpful to get those initial follow-ups with the physician that did them initially, to have those initial follow-ups with the physician who did the procedure, and then, maybe to collaborate with someone closer to home who does
Yeah.
have knowledge on RFA after the fact.
As you well know, nodules look interesting after RFA,
They do.
and especially if you're getting the imaging done at two different centers, the second radiologist who lays eyes on a nodule that's been treated with RFA is going to take a step back and say, "Whoa, that looks like cancer. That
Mm-hmm.
nodule is irregular. It's hypoechoic, hyperechoic. It's just very heterogeneous and not smooth and clean and clear like a benign nodule should
Mm-hmm.
be." And they're going to see that nodule has changed dramatically. If they don't have that context for radiofrequency ablation having in between,
Mm-hmm.
you're going to be recommended biopsies when the patient may not need it.
Exactly. Really quickly, tell us lay people, what are those terms that you were just saying?
Yeah,
Hypoechoic. What do those terms
absolutely.
mean? Yeah.
Absolutely. And so these are all characteristics we build into, like you said, the movie of an ultrasound,
Mm-hmm.
looking at a nodule and saying, instinctively, we have a gut feeling. Is this nodule brighter than the surrounding muscles? That would be hyperechoic. That's
Mm-hmm.
usually a good sign. If it's hyper or iso, meaning equally bright. But hypoechoic nodules are a little bit more suspicious. That gives us some small amount of concern.
Mm-hmm.
Same with those microcalcifications, those small calcified portions of the nodule.
Mm-hmm.
Those factors, along with something that looks irregular, that's not smooth like a ball, that's lumpy and bumpy, all of those things in
Right.
combination add to our concern incrementally.
Mm-hmm. Mm-hmm. Lumpy and bumpy. My nodule, I was just reading my report from my ultrasound last summer, and my nodule has shrunk into an L shape.
Yeah, there
So
you go. See,
it's so strange because it was this
yeah,
one giant nodule that had actually been formed by multiple nodules that kind of fused.
sure.
And so over time, as it has shrunk, it's turned into an L.
And
So
if a radiologist or an endocrine surgeon without the context of that is going to scratch their head at that, because they're
yes.
going to say, I don't know if I've seen a nodule that looks like this.
Right.
And when in doubt, we defer to biopsy, right?
Mm-hmm.
If our spidey sense goes off. So yeah, definitely good to, and obviously it's a small community here in the radiofrequency ablation community. So
Mm-hmm.
it's easy enough to transfer care to another doctor. And I think most people are probably happy to do that.
Thank you for clarifying those terms.
Of
It's
course.
I was talking with a colleague just this week about how the closer you are to this, the easier it is for us to use terms. I use a lot of these terms. You physicians always use these
Of
terms.
course.
And then I have to remember the patients, they don't always understand what these terms mean. And so my goal is just to
Absolutely.
make this lay people friendly. So
No, totally agree,
so
and
helpful.
with the caveat that I'm often impressed by the patients who come to see me for this. I think most patients who come to see me and have heard about this, if they didn't hear about it from their doctor who referred to them, they've found resources like your podcasts and Facebook group, and so I'm impressed by how much they know. They've read papers. They're very much advocates for themselves, and I think because knowledge about this is still growing, sometimes they're the ones who are bringing it up to their doctor, and so I'm always impressed sometimes by how eloquently patients talk about their own disease process, because it may not be the normal thyroid patient.
You are exactly right. This is a group of patients who are extremely diligent to educate themselves. And I'm so impressed when I see that. Very, very little victim mentality of our patient population. And so I always am impressed at how willing they are to read science papers, educate
Yeah.
themselves. And so that's the goal here, is just to constantly be providing them with more resources that are geared towards patients. So thank you for that.
Yeah.
Let's see. Let's talk about your philosophy of patient care, because this was something you sent to me when I was preparing for this interview. And so I love your philosophy is deeply rooted in compassion, respect, and open communication. And you believe that personalized and collaborative medicine is the key to providing lasting improvements in patients' lives and well-being. Wow, you just won me over right there. So let's dive into
Well,
that for just a minute,
yeah.
because that's something that patients are constantly complaining that they can't seem to find. So tell me
Mhm.
about how you kind of developed this philosophy for treating patients.
Yeah, yeah. I think like anything, it comes from previous experiences.
Mhm.
I trained at really, really big public hospitals, Jackson Memorial in Miami and Parkland at UT Southwestern. These are patient populations that are underserved, and those patients haven't had great access to physicians often.
Mm.
And so you get in the habit of addressing multiple things at once and kind of talking more to the patient than your average quick visit, right? And as I transitioned into this specialty, I think the same is true, especially when you go to a place like Hopkins for training, where one visit is pretty in depth. We're not just talking to the patient about, okay, do you want half your thyroid or your whole thyroid removed? That's a pretty quick conversation.
Mhm.
But when we talk to the patients and say, hey, you may be a candidate for radiofrequency ablation, you may also be a candidate for scarless thyroid surgery. You could do, if you choose that path, you could do a lobectomy or a total. Here are all of your different options. And I'm amazed each and every day about how you can't fit one patient into a box, right?
Oh,
And
definitely.
the nice part is that by having all of these different options available, you can get into the nitty gritty of what's motivating the patient, what they're
Yeah.
worried about, right? Because if a patient tells you, hey, I'm really worried about having to take thyroid medication,
Right.
then I can suggest a different solution to them than if they say, hey, I don't really care about the thyroid medication, I just don't want a scar.
Hmm.
And we can offer them something else. And then some patients say, I just want the most direct, definitive, quickest result. And for that
Hmm.
patient, surgery may be the ideal scenario. And so the more options you have available, I think you have to kind of believe in personalized medicine and understanding what makes a patient tick.
Hmm. Most definitely. And I can hear echoes from Dr. Russell when I interviewed him about this several years back, because
Hmm.
he was talking about the same concepts there. And so I can definitely see that he had a massive influence on you and your training.
Absolutely. Yeah, yeah. He was an amazing mentor and obviously learned pretty much everything I know about these things from him. Yeah.
Hmm. Hmm. Well, I know patients are going to be so excited to find you in the Clearwater area. Just hearing you, go through all of those reasonings for your philosophy. So, okay, Dr. Desai, let's go into this paper. This is the
Sure.
real meat of this interview here.
Yeah. Yeah.
So let's talk about your paper. The title of it is Radiofrequency Ablation of Benign Thyroid Nodules, a Prospective Multi-Institutional North American Experience. Now, this is important,
Hmm.
because here in the US, something I've encountered, and I know you can talk more about this as a physician, is that we in America want American data. And you alluded to this earlier.
Yeah.
Why is that so important?
Yeah, because we've made mistakes in medicine before, assuming that something that works for one group of people works just as well for everybody, right? And we see this
Hmm.
in all kinds of articles that come out now, that maybe in historical studies we excluded women because women were
Right.
thought to have more hormonal shifts, and that might interfere with the effects of a drug or a medication.
Hmm.
Or maybe we had a population that wasn't reflective of the actual population, that the medication was going to be treating.
Hmm.
And so we kind of know that most of the data, because radiofrequency ablation originally became popular in Europe and in Asia, that those studies, even though they showed really outstanding results, they likely correlated, we could assume, which is why we felt safe treating these patients for so long. And
Hmm.
we've seen those results, but we have to prove it. And so The nice part about this paper that I was able to be involved in and write, I had some amazing co-authors. Obviously, a lot of these patients were Dr. Russell and Tufanos at Hopkins, Dr. Kendall at Tulane, Dr. Noel and Dr. Orloff at Stanford. Those are the three institutions that were put together, and we were collectively able to look at the results for everybody. And the nice part about this is everyone has a little bit different treatment philosophy. How big of a nodule they're willing to treat on the small end or on the large end. But we were able to, even with that, create a very similar group of patients. So these are all benign nodules that are causing ideally compressive symptoms or growing steadily. And we were able to look at the outcomes with this. And this was the largest paper in North America and certainly in the United States looking at radiofrequency ablation. We had 620 nodules. And the nice part was, even though there were 3 different institutions, 5 different RFA providers involved in the study, the outcomes were consistent. At 1 year, the nodules shrank nearly 80%, somewhere between 70 and 80%. With one single RFA treatment, which is obviously phenomenal outcomes. In terms of what we consider a successful treatment, which is more than a 50% volume reduction, more than 75% of nodules achieved that within one single treatment. When we looked at factors that influenced successful outcomes, we also want to know about, okay, are there patient factors that are going to allow us to tell a patient, you're more likely to do well, you're less likely to do well with this treatment? Those are important areas of research too. And what we found reassuringly is that for almost every patient and treatment variable, it doesn't matter. It doesn't affect the outcome. Patient sex, patient race, patient age, patient whether or not they're obese or not, and different variability within the nodule. Is it dark or bright, or does it have microcalcifications? The technology seems to work for pretty much every group of patients. The only thing that we found that was statistically significant in terms of predicting a poor outcome was if you have a large nodule measuring over 20 milliliters. Thinking about nodule volume is hard. We're not trained to think about things in nodule volume, but you'll have to take my word for it. That's a relatively large nodule. You have a 65% chance of the nodule successfully reducing versus over 80% if you have a medium-sized nodule or a small nodule. That's something we've anecdotally known for years. It's intuitive, right? Where if you have a massive nodule, you're less likely to have an outstanding result in just one treatment. But what this actually showed, in my opinion, was reassuring that even for these really large nodules, 2/3 of those patients will have, within one treatment, a successful volume reduction.
Can I share with you how large my nodule was?
I think I've heard anecdotally, but yeah, tell me, please do. Please do.
It was actually, they couldn't get an exact accurate measurement on it because it was bigger than the ultrasound screen. So it was between 65 and 75 mLs.
Exactly.
It was
And it's
so big.
hard. Yeah, and I think as we continue to combine data from multiple institutions, we can look at patients like you, right, who have had really, really large nodules. And out of curiosity, obviously, no pressure if you don't want to share, did you end up needing more than one treatment?
I did. And that we knew that from the outset because 20% of my nodule was substernal. And so he did a 2-stage approach. And the first treatment was in July of 2019. The second was in March of 2020. And after a year, I had achieved 90% reduction.
Wow.
So, and I've maintained
phenomenal.
it for 5.
Yeah.
So yeah.
That's phenomenal. Yeah. And those are the types of things that as we gain more research, we can counsel patients on. And we already, we intuitively tell patients, hey, if you have a nodule that's 60 milliliters, it's going to be hard for us to treat all of this in one therapy session.
Definitely.
And even if we do, you might need a touch up a year later. And so, the good news is that even with just one treatment for most nodules, you're going to have a really good outcome. And this kind of proved that American patients are very similar to their Asian and European counterparts. And so we were lucky enough to publish that earlier this year in a journal called Surgery.
Excellent. Okay, so let me just highlight this for a moment. In the results, you have 620 nodules, and out of those 620, there were only 3 nodule ruptures.
Correct. Yeah. Thank you for hitting on that. So,
Yeah.
obviously a big part of this is we want to see how well patients do on the good end and talk about the amazing outcomes. But
Hmm.
patients often, as much as they often come in convinced they're going to get a good outcome because they're familiar with the research. But their question
Hmm.
is, what's the bad things that can happen to me? And when we talk about this now, we have some context for them. In our study, we had only 3 nodule ruptures. Those can be quite dramatic, where it looks like an
Right.
infection and is quite swollen, but they typically resolve with antibiotics and steroids and conservative treatment. We had
Hmm.
one patient who had a little bit more involved of a course where it took a few weeks for that to fully resolve and even had a small skin opening. But it's nice to be able to talk to patients about that and say, hey, even if 620 nodules, this is the likely outcomes. We saw, the rate of voice changes was between 1 and 2%. In all of those cases, that was temporary. There were no permanent cases of injury to any other nerve in our study. And so these were really reassuring. Certainly an overall lower complication rate than surgery.
Hmm.
No episodes of massive bleeding or anything else like that we sometimes worry about with surgery. And the rate
Hmm.
of hypothyroidism or low thyroid level after radiofrequency ablation was similar to other studies, less than 1%.
I would say that between a scar and the need for lifelong thyroid medication after surgery, I think
Mm-hmm.
more patients mention that being their primary concern. They don't want to be needing that medication, dependent on
Mm-hmm.
it for the rest of their life. And so that's very
Absolutely.
exciting to see that data coming out in that paper. I would love to share this in the description of this video, if you don't mind, of this,
A-
the link to
a-
this paper.
Absolutely, not a problem. And I can share with a PDF if you want as well. I'm
Yeah,
happy to
yeah,
do that.
that'd be
Yeah, yeah,
fantastic.
yeah.
Okay, well, we're getting to the end of our time. I have a few patient questions for you, if you
Sure,
don't mind.
sure, absolutely.
Okay. Okay, so this patient, we talked about this a little bit, but this patient asks, do you treat cancerous thyroid nodules or lymph node metastases?
Yeah, very very selectively, right?
Hmm.
And so with lymph node metastasis, it depends, just like the classic saying, location, location, location.
Right.
If it's a lymph node metastasis right near the recurrent laryngeal nerve, I'll tell the patient this is not as safe for you as surgery potentially.
Hmm.
If it's a
Hmm.
lymph node metastasis, especially in a patient who's older, who only has one lymph node metastasis, that could be a very good RFA candidate, depending on where it is. And
Hmm.
in terms of primary treatment for cancers, like we mentioned earlier, very select patients.
Hmm.
I think the outcomes are clearly good enough that I feel comfortable treating it. As long as we have a conversation with the patient and talk to them about what's the unknown, right? We haven't, like we talked about the importance of proving this in American population, we haven't fully done that to the same degree as our Asian counterparts and colleagues have. So,
Hmm.
so with select patients, I'm happy to consider that.
And I just want to clarify 2 points. There's data coming
Mm-hmm.
on that. We're just waiting on
Absolutely.
that to be finished up. I think at Hopkins, Mayo, and Sloan Memorial Sloan.
Yeah.
And then the other point is, I just want to remind the viewers that those metastases are only going to be treated with RFA potentially after you've had a thyroid surgery.
Correct.
So
Correct.
you're not going
Exactly.
to treat someone who's got a papillary cancer and a lymph node metastasis, right?
Completely agree. That's a step too far. I
Okay.
think we're a ways away, and I totally agree with you. I think the research is coming out on that, and I think
Hmm.
uh, part of my willingness to do this is because I was able to be a part of some of that early work at Hopkins that they've continued since, and so I've seen
Hmm.
this technology work for patients,
Hmm.
even with small thyroid cancers, and I've seen myself some of those nodules disappear entirely on ultrasound, and so once you see that makes you a believer. I
Oh
think
yeah.
the full book is still to be written, but uh, I'm excited about this for thyroid cancers as much as I am for benign nodules,
Hmm.
even more so for thyroid cancer.
Definitely. I am too. And I even for the past 3 years have been involved with THICA, the Thyroid Cancer Survivors Association,
Sure,
with their annual conference, because we do host a session about that exact topic, about
absolutely.
primary treatment and metastasis treatment with RFA and other thermal ablation techniques, and that interest in that area is really growing. So thank you for talking with me about that. Okay, the next question is, how small of a nodule is it possible to treat with RFA? I have very, very small but toxic thyroid nodules between 2 and 6 millimeters. And my doctor wants to remove my entire thyroid, but I want to look into RFA first. Now, I would imagine that
Yeah.
the pending variable here would be how many are there? What would you say?
Correct. Correct. And there's a lot of different flavors of hyperthyroidism. I'm actually talking to a doctor in our medical community. Their family member just got diagnosed with that. So we would want to make sure that it's not something like Graves, because something like
Mm-hmm.
Graves is not amenable to RFA. It could be a toxic nodule. Typically, we would identify that on an uptake scan. But
Mm-hmm.
at 2 to 6 millimeters, it may even be hard to see that that nodule is hot. And so I
Mm-hmm.
would say that's a little bit of a challenging situation.
Mm-hmm.
If there's pretty clear evidence that you have one or maybe even two small toxic nodules, this could be something that's considered. As most of your followers probably know, toxic nodules have a slightly the goal is different, and so
Mm-hmm.
they have a slightly lower rate of success than when we're talking
Mm-hmm.
about just treating a big benign nodule. We're trying to eliminate a functional problem, and so we
Mm-hmm.
have to be a little bit more aggressive with removing and treating as much of the nodule as possible. And so
Right.
smaller nodules are helpful, but we'd want to make sure we're not treating a Graves patient or somebody with multiple 5 or 6 hot nodules, because the likelihood of success in that situation is unfortunately low.
Right. Absolutely. Okay. Thank you. All right. Next question is, can RFA be done on nodules that come back with inconclusive results from an FNA biopsy? We talked about this a little bit. And so let's kind of make sure we define, what does inconclusive mean, Dr. Desai?
I completely agree. That was exactly where my head went as well. So, we have a rating system of reporting thyroid cytology, which is needle biopsy results. And this is really challenging. It's looking at one puzzle piece and trying to figure out what the entire puzzle is, right?
Right.
And so I tell patients all the time that, it's very easy for me to say, oh, the cytopathologist should be able to tell us exactly what this is. But it's really, really challenging. We're giving them such a
Mm-hmm.
small sample, right? And so if it's non-diagnostic, if they don't have enough material to assess that, at least in my practice, I would offer the patient a repeat biopsy or even potentially a larger core biopsy, but I
Mm-hmm.
would not treat that patient with radiofrequency ablation yet. If we're talking about indeterminate nodules, what that means is that there are enough cells, but the cells look atypical or concerning in some way. And that
Mm-hmm.
is historically associated with some degree of risk of cancer. And so in that pathway, it goes more towards the conversation of cancer, where it would have to be for small, carefully selected nodules. There
Mm-hmm.
are, just as you've mentioned, studies coming out on this from all over the world. And there's lots of intricacies. If these nodules are indeterminate, but genetic testing shows that they're benign, is that good enough? In my practice, not yet, unless they're very, very small. But
Mm-hmm.
others across the country may disagree.
Mm-hmm. Yeah, we're definitely seeing there's a lot of opinions. And I think it's valid for us to all have differing opinions, because if we all agreed, then how would we ever advance? So,
Correct.
I think that that's important, that we're asking all these questions and trying to decide, is this right? Should we be doing this, or should we maybe step back and think about this a little bit differently? So thank you for defining those terms for us. I think that's so important. We define our terms. I'm saying
Absolutely.
that all the time about different
Yeah.
areas of life in general. What are your terms? What do they mean? Let's make sure we're on the same page. So I think sometimes patients can get confused with indeterminate and inconclusive because they sound similar. Another common issue we see
Absolutely.
is radio frequency being confused with radioactive iodine. And those are totally different things, and they couldn't be more different. So,
Agreed. Yeah,
yeah,
and even radio frequency ablation sounding like radiation. And so
right,
one of the common questions I'll get at the very end of a consultation sometimes is, well, how much radiation are we talking about? And
right.
sometimes it takes me a second to realize that's a very reasonable conclusion to come
Hmm.
to, where you're
Hmm.
thinking that this delivers radiation, and as you know, it really does not, which is one of the
Hmm.
benefits of it.
I have another podcast with that topic in mind coming up soon, and I can't wait to discuss it just fully in depth. So,
Sure.
everyone watching this, stay tuned for that. Okay, Dr. Desai, one last question before we close out this interview. This question is asking, how close do you treat inside the nodule to the edges or the borders of the nodule?
This is exactly what we were talking about, where The patients who come to see us ask awesome questions. These are the same questions we're asking ourselves as proceduralists who do this. And even in the procedure, we're making that decision in real time, right?
Mm-hmm.
There isn't always a fixed answer, because what matters
Right.
is what's on the other side of the nodule boundary, right? If the other side of that nodule boundary is a safe structure, we can get very close to that nodule boundary. If the other side of that nodule boundary is the nerve that controls the voice box or the vocal cord or the carotid artery or the windpipe, the answer is not very close. And
Mm-hmm.
so our goal in general, I think what they're alluding to, is to minimize that outer rim of untreated tissue, because we know in patients who tend to regrow over time, or patients who don't have as good of a response in the first place, it's typically because there's too thick of a rim of tissue. And this is
Right.
what we alluded to before. I think the hesitation early on in somebody's RFA treatments is to leave a larger rim of tissue, in part because I've been able to, even before I started doing my own cases, see so many. I
Mm-hmm.
feel much more comfortable getting closer to that rim. There will
Mm-hmm.
always be a rim of somewhat untreated tissue at the periphery.
Mm-hmm.
That's normal, and that's actually advisable in most cases. But our goal is to minimize that as much as we can safely do so.
And the only time when that's not the case is when you're treating something that's not benign, right?
Correct. With cancer, that
Mm-hmm.
paradigm changes entirely,
Mm-hmm.
which is why we have to be careful about where the cancer is. It's not
Mm-hmm.
just the size, but if that nodule is right up against, that cancerous nodule is right up against the windpipe, you're not going to be able to, quote unquote, get a margin. When we talk about surgery, we want to get all the way around the nodule. And with
Mm-hmm.
radiofrequency ablation, some of that is true as well. We want to treat the very, very edges of the cancer with heat too, because having a little bit less cancer is not the goal of treatment, right? The
Mm-hmm.
goal of treatment is to eradicate cancer.
Absolutely. Oh my goodness. Dr. Desai, this has been so educational and informative. Thank you so much for answering all of our questions. And I am excited for patients in the Clearwater area to meet you and have access to you now. What's the best way for patients to find you if they want to reach out to you?
We're really excited, Jen, to offer this in
Mhm.
Tampa Bay. Like I mentioned, it's kind of an underserved community, and we're seeing patients
Mhm.
from all across Central Florida. We know that this isn't an area where patients are going to be traveling 1,000 miles always to come see us, and cost consideration. So we try to offer this work with insurance when we can, and if the
Mhm.
patient is self-pay, to really make it as affordable as possible. And we're excited to really offer this pretty much as cheap as we possibly can, because I think there's a lot of irony in patients having to have surgery because it's the cheaper option. That's kind of crazy.
I
And so
know.
that's one of my pet peeves. And so we're excited to offer this, and try to make it feasible for as many patients as possible. In terms of where to reach out to me, my practice phone number is part of ENT Associates. Our website is entflorida.com. And you can ask for an appointment with me at our Countryside location in Clearwater. That's where we do our ultrasounds and our procedures, and everything else. And if they have
Mhm.
any questions, they can feel free to reach out to me directly. I have an Instagram page, which is Tampa Bay _endocrine surgery, or through any other contact form is fine. My email is good as well. That's ddesai at entflorida.com.
All of that information that you just quoted will be in the description of this video for anyone who wants to go there and find it to directly click on it. So, as well as the link to Dr. Desai's paper that we discussed at length. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.